Hello everyone, today we'll be discussing pneumothorax. Pneumothorax is a collection of air outside the lung but within the pleural cavity. So this usually occurs when air accumulates between the parietal and the visceral pleura inside the chest. The air accumulation leads to increased pressure on the lung, therefore making the lung collapse. So pneumothorax can be further classified as simple, tension or open. So of notice, if you have a simple pneumothorax, it does not shift the mediastinal structures. However, a tension pneumothorax will lead to shifting of the mediastinal structures, which is the heart and the trachea. The degree of collapse determines the clinical presentation of pneumothorax. Air can enter the pleural space by two mechanisms. So it can either be external or internal, okay? So it can either be by trauma causing communication through the chest wall or from the lung by rupture of the visceral pleura. So etiology. So risk factors for primary spontaneous pneumothorax include smoking, tall, thin body habitus in an otherwise healthy person, pregnancy, Marfan syndrome, familial pneumothorax. Then diseases associated with secondary spontaneous pneumothorax include COPD, asthma, HIV with pneumocystis pneumonia, necrotizing pneumonia, tuberculosis, sarcoidosis, cystic fibrosis, bronchogenic carcinoma, idiopathic pulmonary fibrosis, severe ARDS, Langerhans cells histiocytosis, lymphangioliomyomatosis, collagen vascular disease, inhalational drug use like cocaine or marijuana, thoracic endometriosis. Then, so pneumothorax can also arise due to iatrogenic causes. Okay, so these include a pleural biopsy, transbronchial lung biopsy, transthoracic pulmonary nodule biopsy, central venous catheter insertion, tracheostomy, intercostal nerve block, positive pressure ventilation. Then causes of traumatic pneumothorax include penetrating or blunt trauma, rib fracture, diving or flying. Then we have different causes for tension pneumothorax, which include penetrating or blunt trauma, barotrauma due to positive pressure ventilation, percutaneous tracheostomy, conversion of a spontaneous pneumothorax to tension, open pneumothorax when occlusive dressing work as one-way valve. Then causes of pneumomediastinum include asthma, parturition, emesis, severe cough, traumatic disruption of oropharyngeal or esophageal mucosa. Clinical presentation of pneumothorax is commonly presents with chest pain, shortness of breath, and breathing difficulties. On examination, the following findings will be noted, which will be the patient will be in obvious respiratory distress, there will be increased respiratory rate, the lung expansion will be asymmetrical, tactile parameters will be reduced on the affected side, there will be a hyper-resonant percussion note, decreased intensity of breath sounds or absent breath sounds on the affected lung. In tension pneumothorax, following additional findings are seen, which include tachycardia, hypotension, jugular-venous distension, cyanosis, respiratory failure, cardiac arrest. Evaluation. So for common evaluation, we can do a chest radiography, ultrasonography, or a CT scan can be used for diagnosis. However, the common test that's used is just chest X-ray. Often even clinical findings are enough to diagnose a pneumothorax. Okay. However, the common investigation we do is a chest X-ray. So this is a chest X-ray of a patient with a right-sided tension pneumothorax. So as you can see, the absent lung markings on the right side, and there is a collapsed right lung. Then of note is the trachea and the heart are displaced towards the left, indicating a mediastinal shift. I've made a separate video on chest X-ray findings of tension pneumothorax, which you can have a look at after you're done with this video. So what's the treatment or management of pneumothorax? So management generally depends on the clinical scenario. So for patients with associated symptoms and showing signs of instability, needle decompression is the treatment of a pneumothorax. This usually is performed with a 14 to 16 gauge and a 4.5 centimeters in length angiocatheter, which is placed just superior to the rib in the second intercostal space in the midclavicular line. So after you perform the needle decompression or stable pneumothorax, the treatment is inserting a thoracostomy tube. This usually is placed above the rib in the fifth intercostal space anterior to the mid-axillary line. So that's all about pneumothorax. If you like the video, please like, subscribe and comment. Thank you.